So I was welcoming Venus and I was saying all kinds of wonderful things about her. I apologize for being muted. I was also explaining that we're talking about health equity today. And I invited her specifically because she's a longtime friend, a colleague, someone I've worked with in the past to change how we treat health and our health workers in this country. She's the president and founder of Día de la Mujer Latina, which is a national nonprofit focused on Latino health in Texas. Though she has a national scope, she's headquartered in Texas. So before I hand it over to Venus, we've talked before about COVID and its disproportionate impact on communities of color, on vulnerable communities. We've discussed how it shows the cracks in the system, like it really made it real for all of us. And now we're entering into a post-pandemic phase, yet we're still defining next steps to embrace health equity for real. Like, what does that say about the healthcare system more broadly, but also what does health equity, what could it look like for the Latino community? Now, because of being in this post-pandemic kind of transition, even the discussions on health equity are in transition, and there's a lot of evolution. I've been attending a lot of meetings across the state and at the county level to talk about health equity with officials and leaders in the healthcare system. And what is clear to me is that there are many questions and challenges, and they're recognized, but there's also some indecision about the next best steps to take forward. There's general agreement, but not on process yet. So we still have a lot to review and get through. There's also been a lot of research done on it. But I want to highlight a study that came out at the end of last year by the Robert Wood Johnson Foundation, because what really struck me about it, it asserted the need for better data collection in healthcare. And actually the name of the report is Charting a Course for an Equity-Centered Data System. And the president and CEO of the Robert Wood Johnson Foundation, he really lays it out in the first paragraph. He says, public health data should reflect the needs of everyone in America, regardless of their race, where they live, or how much money they have. If we're to become a nation that truly values health equity, public health data must reflect fairness, justice, and inclusion as fundamental requirements. Implicitly, the data itself is unbalanced. If we don't have basic data, it's a little difficult to determine what the problems are so that we can address them and seek out best solutions. So it's in this can-do spirit that I've invited Venus to be part of our session here today. Generally, we'll talk about best practices, addressing hesitancy, deterrence to Latinos to access healthcare, communications generally, community health workers, lots of topics. She's on top of all of them, and I would say more than just on top of it, she's ahead of the curve. So welcome, Venus. Thank you so much for being here. I would love it if you could open up and tell us about your personal journey and how it led you to the creation of Día de la Mujer Latina, because I think that story in and of itself is pretty powerful.
Yes, gracias. Thank you so much for inviting me. This is exciting to see what's going on in Maryland. I am a sister city now for us. So let's see what we can do. Sister state, I'm sorry. So let's see what we could do together. Juntas podemos. Remember that. So Día de la Mujer Latina started because of not only my breast cancer experience, but my sister's untimely death to cervical cancer. And so in 1992, I was diagnosed with breast cancer, and I was trying to push my whole family to get their breast cancer screening. And my sister kept saying, well, yeah, I'm on my period. I'm still menstruating. And I finally said, this is way too long. You can't have periods that long. And then when she finally did go, she found out she had cervical cancer. My sister died 9 months later. And it hit me so hard because I kept thinking, I was so focused on breast cancer that I didn't realize that there's other cancers that really, impact Latina women, and we may not know about it. doing a little bit more research back then, the research was Black, white, and other. And Gabby, you remember me? I was like, no, this is not right. Way back when I was on my visits back and forth to Washington, I said we need to have, you know, our face and our names and our ethnicity. We need to be included as a separate identity. And in 1997, I was one of the 12 people that sat in front of a congressional panel, and we worked to get the term Latino back into the OMB 15, which is what we've used now, is Hispanic Latino. And our focus was the fact that, you know, as Latinos, we come from 22 different countries of origin with specific demographic patterns and degrees of acculturation. So we need to focus on us individually. And I did that with 1997, our first Health Fiesta. And I pulled in some of my girlfriends in Atlanta, and of course, being in Atlanta with CDC, I had some friends at CDC, and I started the first Promotora training there. And we hosted the first Health Fiesta, and we had about 257 people registered. And Gabby, by the fourth year, we had them in the thousands. People were all around. We had 12 mammography vans already participate. It was huge. And it made us realize that, you know, you build it and they will come. And many of these people, especially women, did not have health insurance. And this is in the height of the big increase in the South, where we saw in Atlanta, you know, and other places in the South, the increase of Latinos. And so our goal was, you know, to get to the women before things get really bad. And just to give you an example, the first year we did 202 pap smears, because that was our focus, is breast cancer and cervical cancer. And out of the 202, 84 had HPV. And so we realized then that we needed to really look at these sexual transmitted diseases and how it can relate to, could morph into cancer if not treated early. And that's how I started with my work around the country, setting up these Promotora training models and the Health Fiesta, our signature Health Fiesta. And you know, we started to grow, and I don't know if you saw in the map, but we've grown, you know, 40 states in Puerto Rico, Dominican Republic, and in 2019 we started in Mexico. Our Promotora training is now part of the University of Baja California Sur in Cabo. So they have taken our training to train, to have the training, Promotora training there. So I never in a million years thought this would happen. As you know, my history, even discovering breast cancer, that I had breast cancer, that was all, I would say, you know, synchronicity. It's just, I never knew that I would, you know, have breast cancer.
So, wow. It's such a, you know, when you told me this, so I'm going to share a little bit about our story so people know why I'm talking to you like you're an old friend, because you are. Venus and I go back. When I was in the Obama administration, I was at the Department of Labor, and she did something along with a colleague of hers, Maria Lemos, who they really raised up the issue of community health workers and the importance of community health workers to the Latino community. Now, this was probably 2009 through 2013, right? More or less, when we were going back and forth and talking. And she literally changed regulations at the Department of Labor, but I was very honored to help facilitate that, which goes to the issue of representation, which you've heard me talk about before, audience, the need and that representation matters when there's people in place who understand where you're coming from and are willing to carry the water for you. It's critical. But I want to get back to Venus, because Venus, you've had this unique perspective, and on top of it, you started in a state like Texas, Houston, you know, the third largest receiving area of Latinos in the country, and has been for decades. Health equity, you know, in Texas is a very, it's truly a diverse issue, especially in Houston. I mean, so many people are there. It's a lot like Maryland. Maryland is equally very, very diverse. Now, our population isn't primarily Mexican origin. It's Central American and Caribbean origin, and South American. It's all those 22 countries. They're here, and it's exciting. But you have been looking at the health equity lens from a large city a large receiving area in a large state. We're not as big, right? So what thoughts do you have about health equity for us, what you've seen on a national level, because you've also worked in Mexico and in the Caribbean, right, in Puerto Rico. And so what does that say to you about the issue writ large? Easy topic, right? And what should we be thinking about?
Well, honestly, you know, I've been doing advocacy work, you know, since 1997. You know, we're in our 25th anniversary here as an organization. So we've been hearing playing the same old tapes. You know, it's always been health disparities, and then you have people that, you know, that are specifically tailored to run for the money when the money comes out in funding, and it always stays up top and it doesn't trickle down to the community. And I think, you know, right now the public health system needs an overhaul. Basically, that's what I believe. I believe that we need to integrate community health workers and promotoras into all aspects of health and wellness. And I say wellness because, you know, we have to open up the issue of mental health as well. This is something that has we have been working on, you know, very seriously lately since COVID too. But, you know, we have no choice. If we're going to achieve health equity, we've got to look at the value that we have in our community and use those resources in a very effective way. We need to be partners in all planning, strategic planning for any kind of government program that's going to affect the community. We need to have our representatives there, our community partners, our faith-based, community-based, our Black and Brown communities there, providing some feedback. And as their people are in there developing all kinds of plans that we know that they're not going to work, then they come back to us and give us the blueprint and said, here, run with it. And we're saying, no, you know, it's a waste of our time. And then they say, you know, here, we need these promotoras. Can you give them $25 gift cards? No, not anymore. So I think going back to your question, let me tell you about health equity for Latinos. This is there's a lot of emphasis now in health equity, and in a perfect world, everyone, regardless of color of skin or how much money they have in their bank account or you know, race or ethnicity or even age, health equity means that we all should have the opportunity for optimum health and wellness. And unless we remove those system and cultural barriers, we're going to be playing, like I said, the same old tapes. And one of the things that I have seen over, even with COVID, and COVID exposed all this for us, is that, you know, we still are playing with the same players. We're still working with the same players, and the government does not see the value of community health workers and the community partners. And like I said, faith-based. When we were looking at trusted members, people would go to these same old people that they know and they trust. But, you know, they don't ask us. They don't invite us to the table. They don't ask us for help. They just give us, you know, here's the agenda, run for it, and we'll give you, you know, $10,000 to do, you know, 12,000
$1 million worth of work.
Yeah, absolutely. And so, like I said, it needs an overhaul, and it needs to have us at the table. As we are preparing for this overhaul, we need to look at every aspect, the aspects of diabetes, you know, hypertension, all of these chronic diseases and infectious diseases. And then, like I said, mental health. We need to start looking at ways that we can reach our communities effectively and respectfully, because, you know, throwing out information, like I cringed when I saw the first infographics that had just featureless faces. And I called it, and I'm talking about a lot of money went into these infographics for COVID. And I said, please remove those. For some of our Latin American countries, a featureless face means domestic violence. You're giving out the wrong message. So again, it is, we see this over and over. They have a small group of people that they talk with, and they think that that's okay, that this is what's supposed to happen. They don't talk to us.
Right. So I'm hearing the need for strategic communication, even at the leadership, especially at the leadership level, in order to be able to, you know, one, do the communications piece, get the message across. One thing I wanted to to raise was, can we go back to your community health workers again? Because you're doing something that I think is really critically important. And you've really begun to build this idea of expanding the role of promotores or community healthcare workers much more broadly. And my understanding is that you have an accredited training program. And I believe you told me you've trained over 5,000 community health workers in a number of states. Tell us about that training, and maybe dig in a little bit more about what expanding the role could look like. And the reason I'm asking is there's a lot of concern here when you read the health equity reports that there are not sufficient bilingual people, and that's in any language, of course. There's a lot of, we have a lot of refugees here in Maryland, but also that there aren't enough primary care workers or enough mental health care workers by county. I see the promotores and the, as community health workers as an entree into the medical health field, because they can continue. This is sort of like an entry level, which it actually isn't entry level anymore. It's actually quite sophisticated, but it's still an entree into a field that is growing, that we need, and where there are clear barriers. So why not build our own pipeline? So tell us a little bit about that.
Sure. Well, Texas was the first state in the nation to create the certification model that we have now, and it was, legislated by, in 1999, and they at that point, very innovative, said, we don't care about where you're coming from, as long as you get the training from an accredited training program, what they call sponsored training program. We will recognize the role of promotoras and community health workers in outreach. And so what we saw is the opportunity to apply. And when I first applied to be a training program, it was very rigorous to try to get there, but we were the first community-based organization, Latino community-based organization, that was approved in 2009. So it took 10 years for the state of Texas to start looking at not having just community college offering these trainings for community health workers. It really started working. They started working with our community. And when I got in, of course, I brought in my colleagues. And as you can imagine, we started growing. And then the whole training program, we started having more and more folks that represented the communities of color that we have here. Of course, in Houston, we speak 91 languages, so very, very diverse, yes.
Yes, you are.
And so what we did is we started in 2011, I started the first conference, expanding the role of promotoras and community health workers and I would pick a topic. And in 2010, it was all about health reform and health literacy. We went on and on. Every year we had a different theme. In 2016, of course, we were looking at Zika. So our training program, was really highlighting dispelling myths about Zika. And that's when we introduced coronavirus. I mean, basically the virus itself, the family of the virus itself. And so in February of 2020, even before the pandemic was even announced, we had already developed a training program for promotoras and community health workers in Spanish and English on dispelling myths about coronavirus. And by March 15th, we had already trained over 3,000 promotoras and community health workers just on dispelling myths of COVID-19. And when we had the pandemic, then all of a sudden I realized something was wrong. We needed to do something more strategic. And so we put together, we got funded to have 10 hotlines in Texas. So we had, the Valley, we had, Dallas, Fort Worth, Austin, San Antonio, El Paso, Houston. We had all of these hotlines and we wanted to reach the people immediately. And one of the first things that happened is we started getting calls about domestic violence. And we said, oh, okay, we're in trouble here. There's a lot of issues here that we need to do. So in the state of Texas, the training involves what we call 8 core competencies. And every core competency has to have at least 20 hours. So when I develop training, I develop it in English and Spanish. I develop it in such a way that it's very community-based, it's very practical, as opposed to theory-based. And some of the universities that are my colleagues, they're focused more on theory, where I am right there teaching them how to do blood pressures, how to do diabetes screening, how to do vision screening, get on in the road, get on the streets, go to their churches and have this conversation with the community. And that's when, and they all wear their fuchsia shirts, and people recognize them. We do phone banks, and these promotoras are really on top of it. So in 2019, I took them all to Austin to meet our legislators because we wanted more recognition, and our role it was still stuck in administrative services for Medicaid. And so we wanted to have Medicaid reimbursement for our community health workers. Mm-hmm. And so a bill was enacted, and we are still waiting to hear. But right now we're looking at moving the role of promotoras to care coordination, which would help a lot of promotoras and community health workers, be reimbursed and effectively. And more clinics can have promotoras and community health workers in their world. So getting back to the training, this year we looked at the whole last 2 years, and Gabby, as you can imagine, we've been hit with a lot of things. The behavioral health issues. We had training on depression, anxiety, stress, and stigma. We had training. We figured, okay, we have to empower our community health workers to get into research. So, thanks to some funding that we had, from some Bristol Myers Squibb for one, we were able to get some funding, and Pfizer, we were able to get some funding on educating community health workers about clinical trials. And so I developed what we call a clinical trial community navigator. This is a training where now community health workers can work with researchers and be there from the beginning on helping develop that protocol and saying, okay, this is not going to fly in our community. Let's regroup. And that's what our goal is. The training that we have now coming up, the governor of Texas gave us a proclamation, Community Health Worker Day in Texas, and we're really excited. Yes, we're really excited about that. And our, again,
you really did get a proclamation.
This is it. I mean, if you can see this is our proclamation, with the
Wonderful.
seal and everything.
Congratulations.
And having that recognition is, I think, important in Maryland. We need to work. I'll work with you all to see how we can, model what we have here and the advocacy piece that we have, and work together. So, sister cities and sister states, we need to work together to get more promotoras and community health workers, recognized and integrated into the healthcare system.
So I'm reading the chat and I'm having fun because you seem to already have a lot of allies who are saying, let's see, there may be an opportunity to create a program in Baltimore City. Can you send us info about the training? I put your website on the chat. And then one of the biggest challenges is the training that sometimes is not paid for by some employers. And all trainings, even though they may include all core competencies, are not the same or may not be robust enough. I would add to that for, at least for, the Latino piece, the communications piece is really important as well. You were saying about communications, you created all these hotlines, and one, you end up hearing about other issues, which is the beauty of the community health worker. I think there, one of my colleagues, Walter Saba, he calls it the last mile between the community service and the client, or not the client, but the population, the community that it serves, right? Mm-hmm. And they're that individual who are connecting, that connective tissue to make sure that they understand what they're facing, and when I say what they're facing, I'm not talking a terrible disease, I'm just talking bureaucracy, paperwork. Right? I mean, these men and women are playing a role that is very important in terms of helping the individual get through a system that's very complex on a good day. And the interface of that system with other systems, especially if we're talking someone with an immigrant status that is not, they're in flux, let's say, either here without documentation, or alternatively have a visa and their visa expired. It could be a whole host of issues. And our community health workers learn how to navigate all of this and help the patient the individual navigate and their families understand what is what. So I think
I did want to say, Gabby,
go ahead.
that if you go to our website, our training model and curriculum is on the website. So anyone who wants to look at Promotora Community Health Worker Training, we have the outline and everything there. So we are here to help, and especially now, you know, connecting with you, Gabby. You let me know what I could do, and I'm there for you guys.
Oh, that's wonderful. I have a feeling you're gonna have a lot of new best friends. We're going to be asking you for support and ideas, because that's the other thing. I feel this is a field that is innovating a lot and making a lot of changes. So speaking of communication, you know, one of the things I just did a community survey a couple months ago, and we just got the results. And one of the barriers to access is language, right? But I feel that you raised something that was also important, which is how the communication is done beyond language. What kind of expression is used, what kind of images are used, are equally important. Communication is more than that. So why should we think beyond bilingualism? What are the kinds of messages that work? Does it vary?
Yes. Well, one of the issues that we found that has impacted our community, of course, is health literacy. Much of the health promotion that's been out there has been geared to 15% of the Hispanics in this country, where 85% of our Latinos are left out. When you put together any kind of promotional material, educational material, even in our government websites, believe it or not, when you have all of this text and no images, it's not inviting. I mean, I was trying to find something in one of the big government websites in Spanish, and I couldn't even find any tab that says Spanish or Espanol. And
it's tiny, and it's like in a little corner.
And you can't navigate. It's like we like exactly what it is. It's just telling us we're an afterthought. You know, here is all this message that we want you to throw at you, but then a little corner, if you want to know more about it in Spanish, here it is. And that's really hard for some of our people to understand. And just to give you an example of beyond language, when you keep putting so much millions of dollars toward, you know, having these third-party vendors put together these materials, they literally translate these things, and they don't use the culturally and linguistically appropriate model that OMH has put together as part of class standards.
That's
and,
right.
and this is something that the government should have been on top of, because guess what happens? When you put together a program like the word, you know, it's just a shot in the arm. And then you translate that into the Spanish, es un disparo en el brazo. You know,
we saw
disparo,
that in social media.
I mean, this is the kind of thing that we are up against, you know, constantly trying to go back and provide feedback. Take that out, you know, this doesn't go, this, you know, don't say immune deprimido, because deprimido, the word deprimido means sadness and depressed.
Depressed.
You know, and so we would say, no, this is how you say it. And then I found out that they, you know, even one of the biggest health agencies in the country, they were using a Spanish dictionary from Spain, and a little bit outdated, instead of having one here. And our community health workers and promotoras, is part of their communication skills. They speak from the heart. And when you speak from the heart, it's a totally different language. It is more relaxed. It is more respectful. It's warm, and people are more receptive. When you start saying you should do this, you should do that, people will shut down. But when you say, you know, it would be great if you could do this. It would be great if you can get vaccinated, because instead of you should get vaccinated,
it changes the dynamic.
It changes. So that part of communication skills, we spend a lot of time on that, because it's important. Another thing that we work on a lot of is cultural competence. We think it's important for, you know, healthcare providers to understand the all aspects of our culture, not just of our Latinos, but other cultures.
That's right.
And I think we do have a healthcare system that's not culturally competent. So that's something I like to see in the future as part of the overhaul, is really making it not only accessible, but a requirement.
One of our, in the chat, one of our members says, I would like to see some training beyond English and Spanish on how to use an interpreter. Because when you bring an interpreter into it, it does change the dynamic as well, right?
Yeah, absolutely. And I'm a medical interpreter myself. And of course, we always say, you know, look at the patient. Don't be looking at me. I tell the doctors, don't look at me. Look at the patient as you're talking. You are having a conversation with a patient. But some providers, they only look at the interpreter and totally dismiss the patient. And the patient feels left out, confused. And again, that's where we feel that my motto is, you know, my slogan is misinformation plus miscommunication plus misconceptions equals mistrust. And that just raises the mistrust level when you do something like that. So we train our promotoras and community health workers when they are acting in the role of interpreting or being there as a companion for the patient, is to remind the provider to just stay focused on the patient. And I'm just an invisible person with a mouthpiece.
So that's actually a great segue, because you have a campaign, No Más, No More, which says just that: misinformation plus miscommunication equals mistrust. Tell us a little bit about that campaign and how it works.
That started just because as we pulled our promotoras and community health workers together on a focus group, we just said, you know, what's really happening here? What could we do? And they were all saying, you know, the mistrust has escalated to a point that's very serious. You know, even when we put together these programs, they're still nervous about coming, and then they have all this information that they're getting from Facebook, and we felt like, okay, we need to take a stand as communities of color, because it's not just about, you know, a language. It's about health literacy, and it's about literacy in itself. When you throw all of this, people who are, whether you're pro-vaccine or anti-vaccine, when you use scare tactics, that really confuses the person. But sadly, Gabby, when you see that the government doesn't push down, doesn't help us in a way, like, you know, breaking news, this happens. We as a community organization feel that the government should immediately come back to us, to our community organizations, our community-based organizations, our faith-based organizations. Those of us that are on the ground, the foot soldiers, they need to come to us immediately and say, this is what you need. This is the language and the tool kit that you need, and the talking points that you need to work with your community to debunk that misinformation. We don't get that maybe for 2 days. In 2 days, we have a meeting, a conference call, and then they come and tell us. We need that right away. We need that on record on a daily basis. Misinformation is coming to our people on a daily basis. So we need that kind of communication from Washington and from our legislators on a daily basis.
I think part of the challenge for our community in particular is because we come from so many different countries, we actually get information from countries of origin. And you know, that old game telephone, by the time it gets to us, it's completely discombobulated. And it is, you know, it's such a challenge, because if QAnon is alive and well, you know, in English speaking countries, there is an equivalent in Spanish speaking countries as well. I also want to raise up a point. You said it's like we talk about English, and we always know the difference between British English and American English, and we don't think twice about it. We just understand that it's different. The same applies for Spanish, right? Depending on what country you have, there are nuances. There are certain things we say slightly differently, and what the same word can mean different things in different places, or have different implications. So you have to be really thoughtful when you describe things. The disparo in the arm, the shot in the arm, literally it's a gunshot. So not exactly conducive to vaccinations.
Yeah, and when we're talking about clinical trials, you know, we really want people to understand the research has been there a long time. It's not just something that just started. And as we were trying to do that, you know, the government kept using the word ensayos. And ensayos here for us, it means, literally, it means experiments. So when, when you're talking about all these experiments, instead of saying estudios, so
Right.
I had to go back, and luckily some of the bigger companies have removed the word ensayos once they realized it meant experiments, and now using the word estudios clínicos. But and then the demographics, when they translate Black and African American, in Spanish it's negros, and negros is derogatory to us as well. We don't call somebody negro. That's something that is, we could say a dress is negro, but not a person. And but then you don't. That's where the OMH class standards comes in, is having that piece to go back and say, okay, let me run this by this organization that primarily works with Latinos to see if they might be offended by that. And that's the key. That's why I think we still need the overhaul. We need to have Promotores and community health workers there. We need to have them also for emergency preparedness.
Right.
This is not our first rodeo here. We're going to have other issues. And
climate change, when you have a tornado or a flood, et cetera, how are the emergency healthcare workers being trained and supported as they engage with all these different communities?
Absolutely. When we had Hurricane Harvey here in Houston, many of our promotoras got together and they were making tamales, and we carry like 200 tamales to the stadium, and they rejected us, and they said we're supposed to be part of this organization that will decide who is allowed to volunteer or bring anything into for this emergency preparedness stuff. And I'm going, our people don't eat this kind of canned food that you're giving them here. They'll eat a tamale. And so this is just not being part of the elite group. When I checked in to see how I can join this elite group, I had to pay $150 membership fee for the year.
To be a volunteer?
To be a volunteer, to be recognized as a volunteer organization. And when I see this, I'm thinking, it's all follow the money. This is not a commitment to community. This is just a convenient checking the box.
Wow. So I'm gonna raise the CNN story. So I reconnected with Venus because she was featured on CNN. Talking, it was pretty powerful link, basically challenging the format of how nonprofits have a relationship with government. And I know we've had something similar on a smaller scale in some instances here in Maryland, where especially smaller nonprofits that are providing services are really challenged because the grants that we receive from the government, we have to put our money up front and then we get paid in return. And it's all, in the proposal, and it's all written out and drafted, but at the end of the day, they have to accept our invoices. Talk to a little bit about the bigger picture around that, because it can border on crisis for some organizations if it takes 3, 4, 5, 6 months to pay. What are some of your thoughts on how we could improve that system? And if you want to share a little bit about your story, feel free. I'm sure they'd be interested.
No. What has happened is that,
the article is in the chat. Sorry, go ahead.
Yes. What happens is that, unlike big institutions that have millions of dollars in funding, nonprofits don't have the luxury to front out 4 months of paying, community health workers or community organizations to do this work. And yet they report the milestones on a monthly basis. So as I was reporting all the wonderful work all of these partners were doing all across the state of Texas, I kept putting in invoices and they weren't being paid. And then through one of those emails, I found out that they had labeled us high risk. And I asked, wait a minute, what is this high risk? And they said, you weren't supposed to see that. And I said, well, what does it mean to be high risk? And they said, well, you haven't had an audit in a year. And I said, so you've negated all the 20-some years that I've been working with the community, paying our taxes and doing all this stuff. And you stopped, and why didn't you tell me ahead of time? So they waited 4 months to even give me a purchase order number for me to even for them to recognize.
But they granted you the contract.
Oh yeah. I mean, we were granted that contract, and the contract, we set up a budget for the beginning, an example, $230,000 for the year. But this
It's a lot of money.
but it was 5 cities that we were giving that money to, so they can employ community health workers to do this work. And what was happening is that we kept paying the organizations, and then we started using our emergency fund. And I called attention to executive over at NIH, and I said, we can't do this anymore. This is ridiculous. And luckily the attorney for NIH came back, and she said she was distressed to hear that this was happening. And then they did find others that had been similarly impacted by these metrics that these institutions put together. And I think what has happened is many of us had to leave the program. And the program was really on community engagement. So if you're trying to promote community engagement and you don't even trust your community partner by paying them effectively when they're bringing you all these invoices and receipts, then you're speaking from both sides of your mouth. And so I called attention to the fact that I felt really disappointed. Our trust was gone. We felt that with what's going on now, we found that there was a pastor in Louisiana that was using their bus to go around picking up the elderly African-American women in their community to get vaccinated. And 3 months, and he still hadn't been paid. And that bus was a gas guzzler, and he had to leave the program. So we were starting to get all of these stories. And that's when I said, we've got to come together. Somebody's got to see what's going on with these government. Millions of dollars, Gabby, have been going on for years now, but for COVID, millions of dollars went to all of these entities that have millions of dollars already in their coffers. And we as a community are still seen as an afterthought. We are not recognized to be part of the solution. And that's the problem here, is the fact that we as community organizations have to abide by these metrics. And they, these organizations, these entities that get all the funding, they predetermine the organization's size and operating budget, and as an indicator of its value of the organization's ability to do the work, regardless of the fact that they've been doing this work for a long time. And again, it goes back to, the effective public health interventions need to have a complete overhaul if they're going to be effective. And this, what we call, is a systemic racism. We called it out. And it hurt a lot of people's feelings that I called it out, but I had to speak up, because if we don't call it out and name it what it is, we'll continue to be children of the conquest with our heads down. Okay, we'll take whatever you give us. No, we work really hard. We have some value. I tell our community health workers, you are now a key opinion leader. You are a consultant.
That's right.
You need to, ask not for a $25 gift card for you to do, 200 surveys. That's not going to happen anymore. And again, we're just working toward having some health equity and some equity and economic equity for our Latino organizations, with our organizations, because you have to have it across the board.
It's interesting. We talk about social determinants of health, and we look at an individual's, at the wealth gap and an individual's access to resources. But our organizations are also impacted, and that's part of the social determinants of health as well, because if we're, we are here to serve, we are here to facilitate, to communicate, we will be that bridge. But if the resources then are also, if not brought to the table in an equal manner, in an equitable manner, then we cannot serve well either. So it's almost like a vicious circle. It isn't like a vicious circle, it is a vicious circle. So we're looking to break that vicious circle with you. I want to highlight something. One of our members said, be race brave, after you were saying, instead of lowering your head from the conquista, right? I think that's great. We're down to about 12 minutes here. I wanted to open it up to our audience. There's been a lot of really powerful commentary. Anybody have any questions? Please put them in the chat. We'd love to get some info from you directly. We also have to start a new rhetoric about communication health workers not being an entry-level position. That's true. there's a lot of specializations. I find it fascinating. Our community health workers that we've had the privilege of working with this past year through Malvec, the Vaccine Equity Coalition that we helped launch, they are incredible. Some of them are experts in in-person presentations, and they're very complex, and they really get the community. They're communication experts. Others are actually experts in actual like vaccination processes, and each one has their own area. And the fact that they're bilingual, I think that in and of itself, that is not an add-on. That's actually a key component that needs to be elevated and raised. A lot of what you just compensated. That's right, and compensated compensated properly, not as an afterthought. Again, I see Veronica. Do you want to say anything, Veronica? Yes, hop on in. We got the last 10 minutes. No? Okay.
No, sorry, I was muted and Susana had to unmute me. No,
Okay.
Everything Venus and you have said, you guys have heard me say 55 times over and over and over. The skills that we bring to the table, the cultural awareness, responsiveness, and the multi-language is not a favor. You know, it is one of the most annoying things that I actually have clients and partners that don't put that in their budget, and they expect us on the side to translate, to interpret, to prove, and to bring our 30, 40 years of experience. And there's no compensation differential or funding for that. So I think it's a matter of us knowing our value and having, you know, trailblazers and leaders like you and Venus at the forefront saying, where is the budget for this? And, you know, the quality that we deliver. I mean, I don't know if everybody was paying attention, but Venus dropped an entire master's degree in cultural responsiveness with her nuggets. The faces, the shot in the arm, the patience, the interpretation, all those pieces are breathing to Latinos and English learners. But the mainstream American doesn't even understand that there's a difference between American English and British English. They have no clue. So imagine our lack of participation, and it's confusing. And I just think this is a wonderful conversation. And I think the opportunity for us is to amplify the work Venus is doing, borrow, adapt as much as she has done into Maryland. If you have a program, and I'm seeing a lot of chatter, if you have a program that needs to be empowered or to be developed or flushed out, that's why Maryland Latinos Unidos was created. We don't want to start from zero. Si tienes algo, lo podemos mejorar y avanzar, y podemos aprender de Venus, right? And the same thing goes for Venus. Anytime you need a bus full of loud, you know, people, let us know.
So I want to highlight something also. Henry just reminded me, Henry Bogdan, who worked with us in policy. We highlighted a bill, SB 542. I just put it, well, he gave me the link for the chat, but basically it's about prompt payment. It's specifically to ensure that nonprofits or anyone engaging in a contract be paid on time or in a timely manner within, I think it's 30 to 90 days, something like that. Because it is so important, because it has impacted our communities. So we're, you know, we're not looking at this only from the individual, but also the system and the infrastructure that we're trying to build to support the community throughout the state. Any more questions? 7 minutes left. I'm getting reminders.
Yeah.
Yes, go.
I did want to say something else, that, you know, you can also advocate for this as well. I think the government, they use these ratings to decide whether you're going to get funded or not for some of these government grants. And I just recently applied for a HRSA grant. I got 96. There was no weaknesses noted, and we didn't get the grant. And so what we learned, and I started asking questions about it, and I wasn't getting any answers, just the complete back and forth, the copy and paste of their policy. And so I thought, okay, you know, we're concerned because when we went back to look at those that did get the grant, they just were startups. They were not organizations that have been around a long time, and they were getting $6 million. And so what I did, is I raised, so they wanted to meet with me. And one of the things that I raised with them that I think is part of the overhaul is the rating should also give you an extra 25 points if you've been working with the community for at least 10 years. And
Right.
I think I say that embedded in the community, that means that you have been working in advocacy or some form of outreach, but you have actually have experience working with the community at least 10 years. Doesn't mean that you have to be organized, but you have to have show, not just, you know, these startups that I see. We saw so many startups that just started with COVID and we're getting millions of dollars. And here we've been around. So I told them, I said, and oh, they were writing it down. They liked the recommendation, but you know, we have to start pushing our values. And if we've been around and we've been working, we've got so many promotores, community health workers that have been around, you know, doing this for more than 10 years, that has a plus, that has a value.
So Veronica has a little pitch that she's going to make talking about resources that I think is really important. Veronica, you want to share about Baltimore Community Foundation?
Susana has me on a tight leash. She won't let me unmute myself. Me está matando. Hey guys, Baltimore Community Foundation, to this effect about it costs money to reach our community and we have different ideas. So the CDC funded 5 groups across the United States for 2 purposes. Number 1, addressing COVID vaccine hesitancy. But number 2, to learn what works for those hard to reach communities, those Black and brown communities. So Baltimore City, Baltimore County, through Baltimore Community Foundation, received a big pot of money. The money's available as of right now. Applications are super one-page simple, translated into Spanish and English. The request is, if you are an organization, not an individual, we won't fund an individual, but you can definitely get a fiscal agent. You can get funding to address vaccine hesitancy in your neighborhood, neck of the woods, organizations, as long as you're serving hard to reach community members. The campaign that you are seeking money for can be whatever your community needs. You don't need everything. Venus and Gabriela have been saying that everybody wants to have things done to us and we respond or don't respond at all. So if you want to do a Zumbathon, if you want to have a Spanish social media campaign, if you want to phone your promotoras to go knocking on doors, if we want to have a mobile clinic, the goal is obviously increase the vaccines, but learn where are the hangups, what activities work best for the next time we have challenges like this. If we find out that the way to get kids vaccinated is when you have una fiesta con los payasos y la familia, la comida, en la piscina, I'm making this up, right? But if we find out that is what gets the kids vaccinated and the parents comfortable, okay, then let's fund activities like that. So on the chat, I'll repost it. The grant is open. We are truly asking, begging, pleading for our organizations that deal with Latinos, African Americans, immigrants, refugees. Selfishly, I want Latinos, but all of our people need the access.
That's right.
It's about a program, an initiative, a tactic that you know would work. You don't have to do it for free. It's not a volunteer request. There is funding available. The challenge is our people don't apply. So you do have to put in the information. You have to kind of think through and just know you're going to have to report on what happened. There is some reporting, but unlike Venus's challenges, you're going to get the money up front. So if you're planning a crazy idea, let's get some money for it. So please, please, please consider it. Please apply. Everything is in Spanish and English. And if you need any help, ping me directly and we can direct you.
Okay, so I was looking for the link and I can't find it, and I know you put it up in the top.
Yo lo pongo otra vez.
Okay, muy bien, muy bien. All right, so we're down to 2 minutes. There's so many interesting discussions. We've touched on everything from vernacular to the power of our community health workers as advocates and as leaders in their communities. We've talked about your your incredible journey and all the wonderful things you're doing and are going to continue to do, because you're a fighter and I know you're not going to stop anytime soon. We're going to cause good trouble, Vince. We're going to cause really good trouble. Well, we're down to 1 minute. So I thank you. Any last words for us? Thoughts, pearls of wisdom?
Remember, la lucha continúa.
La lucha continua.
Continues. Yeah, la lucha continues.
So we shall be fighting arm in arm. I learned so much from all of you. Thank you for being with us today. And yes, Veronica? No? Okay. I see you're shaking your head. Okay, well, thank you all for being with us. As always, it's a joy for me to be able to share with all of you. And I love the fact that I was able to share Venus with all of you as well. She's amazing, and I'm hoping to recruit her to come over here in person one of these days soon.
Absolutely.
Now that we're in the post-pandemic, we could start maybe seeing each other in person and getting some training going. Thank you. Muchísimas gracias. Que tengan lindo día and have happy travels, Venus.
Okay, yeah, my flight is going to leave in a couple hours. So
I was going to say, she's on her way to a plane, because that's how she rolls.
All right, God bless everyone.
Thank you. Thank you.
Bye.